Hi friends, my name is Dr. Varun Deshmukh, and in this video we are going to discuss about pressure support ventilation. We have already discussed in series of video about basics of mechanical ventilation and PRVC, and this is the next video in line. So we will discuss about pressure support ventilation here. Here the technically if you say trigger limit and cycle, so it is a patient triggered, pressure limited and flow cycle mode. So each breath is triggered by patient. Machine is not triggering breath here, and the trigger you can set as a pressure or flow based on the options in your ventilator. And if the patient makes that much effort to reach the trigger, ventilator will give breath. It is limited by pressure, so that means whatever set pressure above PEEP you have kept in the ventilator, during the inspiration that much pressure will be maintained throughout. And cycling is dependent on the flow. That means if the pressure is kept fixed, gradually during the inspiration the flow will decrease, and at one point it will reach a certain level which will be the point of cycling. Standard point of cycling is 30%. So when the ventilator flow reaches from 100% to 30%, the inspiration will stop and expiration will start, which is a passive process which you know already. So this is about the trigger, limit and cycle of pressure support mode. Now clinically if you see, there are two main applications of pressure support. One is for weaning purpose and second is for prolonged chronic lung disease patients who are on prolonged ventilation. So sometimes you may give pressure support to reduce the patient effort, and sometimes you give for gradual strengthening of the respiratory muscles. So in both these situations you have to know certain prerequisites when you put patient on pressure support. So we will discuss these prerequisites first. So before putting a patient on pressure support, you have to realize that this is a more patient dependent mode and less ventilator dependent mode. So patient has to be fit to be put on this mode. So these things have to be looked at. One is the effect of sedative should be gone or minimal. Effect of muscle relaxant should be not there at all. Patient should be pain free. There should be no fever, and patient should be not be struggling because of pain or fever. The vital parameters should be stable. There should be no extremes of heart rate or blood pressure. Patient should not be on a very high inotropic support. From high, I mean the noradrenaline of 0.1 microgram per kg per minute or equivalent. The dose should be less than that. And patient should not be, of course, patient should not be on multiple inotropic agents at the same time. So also there should be no ongoing arrhythmias. So once these things are assessed and you are happy, the other things that you have to see is patient's oxygen requirement on the ventilator. So oxygen requirement should be less than 50%. PEEP should be 8 or less, and on the ABG, PF ratio should be more than 200. Carbon dioxide level should be within 35 to 45. pH should be compensated. So if all these parameters are fulfilling, you will attempt to put the patient for weaning, and the mode that you will choose will be pressure support. What parameters you can set on pressure support ventilation? So in most of the ventilators you can set FiO2, you can set PEEP, you can set pressure support above PEEP, you can set the apnea time, and in some of the ventilators you can set the inspiratory time also. In our hospital we have Mackey and Draeger ventilator, and we can't set the inspiratory time in pressure support ventilation. You can also set the cycling level. So by default it is 30% from the 100% flow. You can change it to less or more depending on your requirement, and we will come to that when you will change the cycling. So these are the parameters that you can set. Generally we start with the same PEEP that was applied on the volume control or pressure control mode earlier. Preferably it should be 8 or less. So the same PEEP, pressure support, which should be enough to generate 6 to 8 ml kg of predicted body weight worth of tidal volume. So for example, if the patient's predicted body weight is 60 kg, tidal volume range would be from around 360 to 480 milliliters. Generally we start at a pressure support ranging between 8 to 12, and we go up or go down based on the patient's response. So suppose for example we have started with a pressure support of 12, you have to stay at the bedside and monitor the ventilator and the patient's monitor, and you have to see how much tidal volume the patient is generating. If you are happy with the tidal volume, you continue with the same support. If you are not happy, you may increase or decrease the pressure support. We can go down up to 0, so that becomes CPAP, and we can go high generally up to 20. We don't go above 20 because the patient becomes more uncomfortable with high pressures. Also there is cyclic chances of atelectasis with cyclic change in pressure increase. So the range is generally 0 to 20. We generally go between 8 to 12 and plus or minus 2 according to need. So that is the initial setting. Now once you put the patient on pressure support, you are happy with the pressure support and the tidal volume and everything. What things you have to monitor? So you have to monitor whether patient is comfortable and cardiorespiratory wise, whether patient is tolerating the reduction in ventilator support. So you have to monitor heart rate, blood pressure, oxygen level. You have to see clinically if the patient is struggling, if there is sweating. Sometimes if the patient is interacting, the patient may interact with you by gestures and suggest you that he or she is not feeling comfortable. Also you have to see the minute ventilation. So if the patient is becoming tachypneic or patient is developing hypoapnea, both the things can happen, and what is the tidal volume that patient is generating consistently. So once you put the patient on pressure support for the first time, you have to stay at the bedside for 15-20 minutes, see all these things, and if you are happy with these things, then only you may leave and go to the next patient. So but for the first time, always see all these things and be sure that patient is doing well on the change of ventilatory mode. Also I would prefer to put an ETCO2 monitoring when I put my patient on pressure support. That helps me. So whatever the initial ABG may be, I can correlate my ETCO2 with the actual PCO2, and I can know the gap between ETCO2 and PCO2 for that particular patient. And once I know that and I put the patient on pressure support with ETCO2, I know what is the carbon dioxide level range, and accordingly if it is going too high or too low, I can decide on whether continue or whether to stop pressure support ventilation. So keeping an ETCO2 along with the pressure support patient is a good idea. So that's about the practical aspect. Now I will tell you what are the advantages of the pressure support. So the very important advantage from the winning point of view, if you want to say, is that the work of breathing is less compared to standard non-ventilatory breathing, which we call as TPs. So work of breathing is less, oxygen consumption is less compared to TPs. So instead of putting directly on TPs, putting on pressure support will be better from that point. Also patient's comfort is more, requirement of sedation is less because patient is breathing and more comfortable. So you may not give too much sedation, and you may at some point even stop the sedation completely and patient may breathe well. So that is also an advantage. And weaning is facilitated and liberation from ventilator is possible. So of course it is a good thing. So these are the advantages. In a chronic setting, when the patient is on a prolonged controlled ventilation and the muscles are weak, then putting on a pressure support can also act as a muscle strengthening exercise for the patient, and starting with a short duration of pressure support of 5 minutes and gradually building up the duration can eventually lead to improvement in the strength. Of course, with the nutritional and electrolyte correction, it will improve the patient's muscle strength over the days, and probably you can wean this chronic patient faster. So that is also an additional advantage of pressure support as a cardiopulmonary rehabilitation tool. So that's about the advantage of pressure support. Now what are the disadvantages? So as you know, patient has to generate a breath. So if patient is not able to generate breath for any reason, the ventilation will get affected. Patients sometimes struggle on pressure support because they are not comfortable, they are in pain, or there is hemodynamic instability. So you have to keep on monitoring the patient for that. The tidal volume that is generated is dependent on the patient's effort. So the tidal volume can vary. If it varies in a short range, it is acceptable. But if the variation is too much, then the minute ventilation can also get affected. So you have to monitor for that also. Sometimes if there is bronchospasm, the tidal volume will come down substantially because the pressure is fixed. It is a pressure limited mode. So in that scenario, probably you will have to actively monitor this patient for the minute ventilation. In COPD patients, you know that they have narrowed bronchi and they are irreversibly narrow. So in these sort of patients, the expiration has to be prolonged. And when you put these patients on pressure support, probably a good idea is to increase the cycling percentage from 30 to maybe 50%. So when the flow reaches 50% of the maximum, the breath is cycled into expiration. So in that way, patient will get longer time for expiration. And these patients generally have a more air hunger. So that inspiration will be short, but they will generate adequate tidal volume. But while you increase the level of cycling, the duration of expiration is prolonged, and this will help them empty out their alveoli in a better or more efficient way. So that is a good idea when you in a COPD patient especially. when you put them on pressure support. Now an important thing to know is apnea time. So when you put patient on pressure support, you have to also see what is the apnea time. Apnea time is a defense, is a protective mechanism for the patient. Apnea time means when the patient does not take a breath continuously for certain duration of seconds. Ventilator will stop giving pressure support breaths and ventilator will change into control mode. That setting may be whatever, either pressure or volume control depending on your ventilator. But apnea time can be increased or reduced based on your requirement. Sometimes we feel that the patient is washing out excess CO2 and we want the patient to build up CO2 for a few seconds and then the patient might start breathing. So we can increase the apnea time to in some of the ventilators that I have seen up to 60 seconds. Beyond 60 seconds, I am not aware if we can increase the ventilator time. But beyond 60 seconds also, if patient is not taking a breath, then probably it is better to keep this patient on controlled ventilation and wait for the patient to become more alert and more awake. So that is about apnea time. Another limitation of pressure support, I would say, we will discuss that with this example. So on the morning round, we were seeing the patients one by one, and on one patient, the night intensivist and the night team told me that the patient is not able to be not tolerating the pressure support. They put the patient on pressure support in the morning, but within 5 minutes the patient started struggling and they had to put back on volume control. And generally our practice is don't attempt weaning more than once in a day. So if the patient fails the morning session of weaning, then probably give rest to the patient for the whole day and again attempt weaning the next day. So we were thinking whether to attempt weaning the next day, but at that time we noticed that this peculiar waveform in the flow scalar, and this waveform is actually presence of water in the circuit. So when we saw there was water in the catheter mount and also the HME filter was clogged with water. So this leads to increase in the resistance. In any pressure limited mode, if there is increase in the resistance, the tidal volume will get compromised. So patient was not getting enough tidal volume because of that, and we removed the water, we changed the HME filter. Now you can see when we remove the water and change the filter, the waveform is also better, the tidal volume delivered is better, the minute ventilation is better. So overall patient is ventilated better. And eventually we could wean this patient. So monitoring these things is important, and this is one of the limitations. If the circuit or tube gets blocked or partially or completely blocked because of any reason, the patient will eventually suffer, and you will require high level of monitoring for these patients. So it is a good practice to keep on checking for resistance whenever you do suction. Preferably do suction yourself in each shift as much as possible, or have a trained staff and continuously talk with them whether they are feeling resistance while doing suction. Another good thing is use sterile saline, 5 ml saline nebulization every 6 hours when the patient is on pressure support or TPs for a long duration. So these two, of course the risk of infection is there, so be very thorough with the process when you are giving nebulization with saline. But these are the things which can prevent blockage of tube. And of course check your HME filter at regular intervals. In our hospital we change the HME filter every 24 hours, and if the patient has excess secretion, sometimes we have to change it even sooner. But be aware that these problems can happen, and these may lead to weaning failure because of silly things like this, and you can troubleshoot them if you know about them. So that's about the limitation of pressure support. In a recent trial which was published in JAMA, they compared 30 minutes of pressure support versus 2 hours of TPs and 1100 odd patients, and they found that 30 minutes of pressure support was better in terms of less reintubation rate in these patients because patients were not fatigued. So I will put this in the clinical context. So when the patient is on shorter duration of ventilation and lungs is not the main cause of putting patient on ventilator, then probably you can give a short duration of pressure support, assess for extubation and extubate this patient. If the patient is on long-term ventilator support or lungs are the main problem or chronic lung disease is there, then probably short duration of pressure support and extubation is not a good idea, because you have to see the stamina of the patient, and probably you will require longer pressure support or maybe pressure support TPs in an alternate fashion, or maybe even longer duration of weaning, few hours to few days as per the requirement. But definitely for short duration patients and with good lungs, probably a short duration of pressure support and extubation is enough. Now when we are talking about extubation, you need to know about 4S. So before extubating any patient, the 4S have to be seen: strength, stamina, secretions and sedation. So strength is the ability to cough out the secretion if there is any secretion in the throat, which is determined by the forced vital capacity. Stamina is the stamina to continue sustain spontaneous breathing efforts, which is determined by the rapid shallow breathing index. Sedation, of course, patient should not be on sedation and completely awake. And secretions, there should be no excessive secretions and frequent need of suctioning should not be there. So if all these 4 criteria are met and the patient is fulfilling the criteria for weaning, then probably you can go ahead and decide on extubating this patient. So that's about pressure support. I hope you like this video, and if you like this video, please give a big thumbs up. It motivates me to create more content. Please share it with your friends who are interested in quality content in the field of critical care, and I hope to see you soon. Till then, take care and bye bye.